y'all. This is JD from Meridian Fire Department. We are excited to bring to you kind of a different format than what we've done in the past, but due to COVID, we are pleased to have some representatives from Zoll here to discuss with us 12-lead EKGs. We're coming up on the 1-year anniversary of us all getting to the X series, and so we wanted to do kind of a refresher on the 12-lead stuff. And I know that at least people in my department have hit me up about that opportunity, and so we're pleased to have Zoll's education team here, one of their education personnel, Eric Kessler. He comes to us from New Hampshire, and so we're really grateful to have him come talk to us about 12 leads, and hopefully you guys learn some stuff. Look forward to seeing it in the next couple months as we present this to the masses. And with that, I'll step away and let Eric come and introduce himself. Thank you.
Fabulous. Fabulous. So yes, we did kind of customize this program specific for access. And here, as you guys do a lot of mutual aid, you work well together, I understand. I like that a lot. And so we'll kind of address that specifically. The other reason you should ask a lot of questions is if it comes to your mind, even if you already know the answer, there might be somebody in Zoom land that doesn't know the answer and they don't have that opportunity. So if something just pops into your mind that you think you might want to ask, please do, for courtesy to everybody out there. Fair? And you can expect me to answer it directly and honestly. This is my goal. These are my goals right here. Acquisition, localizing the MI, some mimics, and some advanced interpretations. And to be fair, I'm going to talk about these things not from an academic point of view, but why it actually matters. We update our cell phones every, 30 seconds? Every night, every week? I don't know, there's always updates popping up. I believe our medicine should update that quickly, which means when we're done with every presentation going from here on out, what you do in the back of an ambulance should change. I don't think there's any amateurs in this room. As I look around the room, there's been people who have been doing it a very long time. And I just said, I'm going to change your medicine. I hope so, right? I hope you guys will treat your patients differently because of what we talk about today. That might be a bold statement, but I'm all right with that. There's other statistics that aren't up here that I hope you should know. You can tell if I'm doing my job well. At the end of this slide series, you should understand 44%, 33%, 7%, and the rest of it. When I get done, if those statistics change your medicine, I've done something right. If when I get done, those statistics make no sense to you, then I've done something wrong. Fair? Perfect. Let's start with this. This is Dr. Ian Tovin, and he was the guy that literally put one hand in a salt bath, another hand in a salt bath, and built this triangle thing that we all know and love. Why I find that interesting is Dr. Ian Tovin was German, which is why it's considered an EKG, electrocardiogram, not an ECG. Interesting historical fact. So EKG is the appropriate way to say it, I think. I don't know. Anybody recognize that? You're right. You're absolutely right. Don't be afraid. It's the Jarvik 7 artificial heart. When? Let's put a timestamp to that. A little bit later than that, the same time that we put a baboon heart into a human body, remember that? And at the same time Bush Sr. invaded the sandbox. Right? Early 90s is when we started doing that. Right? And we started looking at this. Early 90s in Pittsburgh, a doctor took a wire and put it into the human heart and did this thing called angioplasty, you know, open up the heart, put a spring into it. He almost lost his medical license for that. Dr. Fink was his name. And he almost lost his medical license because, well, we don't do that. And then active MI, you only do that to see what's going on. In active MIs, you do drugs like streptokinase or Redivase, angioplast. Those were the drugs of the time. And this company called Streptokinase and Redivase did a study called the TIMI-19 studies. TIMI-19s, thrombolytics and MI. The 19th study of that was in the back of an ambulance. So yes, in the 90s, they were pushing clot busters in the back of an ambulance. They recognized, well, One paramedic doing that, maybe two paramedics, that might not be the best option. That's kind of risky. But the Timmy 19 study showed us something very interesting. While we are out in a remote location called an ambulance, right, or on scene, we're not in a cath lab. Nobody in the medical field, not nurses, not paramedics, not nurses, not cardiology, not ED docs, nobody in the medical field is as fast as EMS, right? We are quick at getting to the point, we're like STEMI, bad, and we moved that through. And that's when you started seeing 12 leads in the back of an ambulance. And I'm going to talk about how quick we actually are. Let's kind of review that right now. What is anoxic encephalopathy? And without oxygen encephalopathy, without oxygen to the brain. Right? Anoxic and Dane Bramage. What is the onset of Dane Bramage, ladies and gentlemen?
7 minutes.
Yeah, 3 to 5, up to 10, depending on what textbook you read, right? So if your transports are less than 7 minutes, none of this is important to you. If you're with your patient more than 7 minutes, it matters. Yeah? And we're going to address what we can do in those 7 minutes that actually not just saves lives, like yes or no, they're going to die. If they die, we push on their chest a few times and squeeze the football thing on their face and do all of that stuff. But how we can predict 7 minutes out, 10 minutes out, 20 minutes out. Actually understand and be ready for what's going to happen to the patient next. That's where we're going with this. Here's my legal disclaimer. Don't follow me, right? I wish someday the FDA would say just because Eric Kessler said so, it's medical fact. Until then, follow your protocols, follow AHA guidelines, follow what your med control doctor tells you. And as I was coming out of the Boise airport, there are a whole bunch of kayaking in this area, I understand. I did not know this. Anybody to Whitewater? Yeah? Fabulous. That's me in New Hampshire. If you follow me, I will take you places like that. Don't follow me. But if I'm ever here again, I would love to take a whitewater trip with you guys. Fabulous. Yes, I'm about ready to get trashed in a hole, but that's all right. That's all right. So this is what we're going to talk about to begin with. And we have split up this, and we're going to kind of do a layered learning process. We're going to grab a base, and we're going to add a little bit more on top of it, and we're going to layer until we get into some advanced interpretation. We're going to talk about clinical equivalence of acute coronary syndrome. In the past, we had protocols that were chest pain protocols. And we know we kind of moved away from a chest pain protocol for this concept of acute coronary syndrome. The reason that is that we know, and you guys know this well, is not all patients present the same. Not all patients present with an elephant on the chest radiating down the left arm. These are other concepts. And if you remember back to school, when you went to EMT basic school or advanced or paramedic school, you learned the term angina, or the angina, or I got the angina. It's kind of this chest pain that comes and goes, right? It's relieved with rest. It's relieved with oxygen. It's relieved with nitro administration. And cardiology loves that a lot because they would say, if it's relieved, don't come in. If it's relieved with nitro, you're fine. If it's not relieved with rest, you should call 911. Once we show up, and they had chest pain, it wasn't relieved with what they're doing, then they decide to call 911, right? So we're still 5 or 10 minutes out, depending on what your on-scene time is, or your right response time is. 7 minutes is IAFF, right? Then it really is acute coronary syndrome at that point. We do not have the opportunity to call it just anginal equivalence and write it off. The burden is now to investigate deeper, right? Because it was a coronary artery spasm? Was it relieved with nitro? Is it acute chest pain? We got to ask, right? I'm not saying talk about that, but what we have to do is rule in and rule out, or kind of dive deeper into this and not just blow that off. Here's when to do a 12 lead. Please, please, please. Syncope. Another big medical word is a vasovagal episode, right? And they vagaled out, and they're between the toilet and the bathtub. And their vitals are good, and we wake them up, we sit them back in the toilet, we give them respect and dignity with a blanket. 12 lead? Yeah, please. Please. And this is what we're used to doing, right? Radiates into the neck, radiates into the jaw. I like the term gazintas. Hey, do you have chest pain? Yes. How is it? It goes into my neck, it goes into my back, it goes into my left leg. Gazintas, heart attack all day long. Yeah? Dr. Levine did another thing as well. There's the Levine sign, right? Anybody that goes like this is having a heart attack. Called the Levine sign. I think that's reasonable. Or at least you better stop and ask, like, what's going on here? We don't get to just write those patients off. Diabetics, elderly, all of these patients absolutely respond to pain differently. Diabetics and elderly, we know we have neuropathy, right? These nerve degenerating problems. And women, they're just tough. That's all I got here, right? And I don't mind making fun of myself in the lessons I've learned because I'm an easy target. I worked a patient one day that had no chest pain at all. He was pale, he was diaphoretic, he was weak, he was kind of slumped in the shoulders. But I looked at him and said, do you have chest pain? On a scale of 1 to 10, what is your chest pain? You know, that classic stupid question of, on a scale of 1 to 10, what is your chest? It's just stupid. He looked at me and said, sir, I do not have pain, sir. Huh. Very interesting. What do you mean you don't have pain? You look horrible. No, sir, no pain, sir. What I did not notice, and I should have picked up on, was his UDT tattoo. I didn't know what that was. Underwater demolition team, right? The frogmen from Navy SEALs, right? The original Navy. Is he ever going to have pain? No, he is not. Stop using the word chest pain in your assessment. Right? That should not, that's a hard way to say that. I should not say that. That's a little bold to put it that way. But please investigate deeper beyond the word pain. Right? Just because somebody does not have pain does not mean they're not having a cardiac event. Fair? Excellent. Musculoskeletal pain, right? If we push on it, it goes away. If we sit them up and forward and they lean forward and that pain goes away, we love to categorize that as epicarditis, pericarditis, not cardiac. Yeah, 44% of those patients, 40% of those patients are having myocardial infarctions in the face of reproducible pain. Still stop and ask and investigate deeper. Fair? General weakness, dyspnea, right? Arrhythmias, dysrhythmias, all of them. Just do a 12-lead, please. Right? So why does it matter? Why would you do that? Like, we're dialing down and saying, do more 12 leads, do more 12 leads. There's a gentleman during World War II named Nicholas Send. He was the father of modern trauma. He stated, the fate of the wounded rests in the person that applies the first bandage. The fate of the wounded rests in the person that applies the first bandage. If the first guy does not do his job well, the second guy's not going to have a healthy patient, right? If that Boy Scout with the first aid merit badge does not stop the bleeding or start CPR, then time starts ticking, and it makes the next guy's job harder. Note the exact time, right? They went to bed last night. Well, why did you call last night? I thought I'd wake up fine. You know, not when they dialed 911, not when you show up on scene, but when did the symptomology start? Perfect. Risk factors. Risk factors matter. Risk factors matter so much. What we know about smoking is it's not oxygen, right? The body loves and runs off of oxygen. If you smoke, it's not oxygen. It doesn't help your cardiac circuit, right? Obesity. That heart has to work harder to move more blood around. Diabetes, all of these risk factors simply make the workload of the human body harder. So if you've already worked in your body harder, and then you have one more stress factor, it's kind of the straw that broke the camel's back. So please ask every one of these things. A classic story is a gentleman like Mike Susi, and Mr. Susi has given me permission to use his name, but he was 33 years old, going through paramedic school. Smoked 4 packs of cigarettes a day, chain drank Mountain Dew, worked during the day, paramedic school at night, clinicals in between. Any of that sound familiar? Had his first ST elevation myocardial infarction at 33. Yeah, if you just stopped at the age of 33, young, tough guy, he's fine. And you start adding risk factors on, it becomes a different story. Please, 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 ladies and gentlemen, every time do a complete history and physical. A tight A&P. If you don't know what this is, just go ahead and read up there. That's bad, right? This, bad. This, not healthy, right? That, not healthy. That's the EKG from triage at a local community hospital. What was unique about this case is EMS signed this car crash off. They showed up on scene and the patient had already self-extricated. So he's up walking around. They did a set of vital signs. Guess what? His vitals were good. They asked the gentleman, do you have any pain? He said, sir, no pain. They did not notice no skid marks, no attempt to stop, no attempt to swerve through traffic directly in the pole. No skid marks tells you he didn't even go for the brakes. He was unconscious beforehand. But because they did not investigate a complete assessment, they signed him off on scene. He drove himself to the hospital. Please, guys, complete history and physical. Fair? And we hear these words all the time. Don't treat the monitor, treat the patient, right? Treat the person. What do you do for a work history? What do you do for social history? Hardworking farmers, mechanics, they're not young men anymore, right? They're not young ladies. Ask these leading questions. Never hang your hat on one thing, right? Oh, he denied chest pain. He's fine. He's too young. He's fine. Fair?